Hello, everyone. Namaste, and welcome to ISCCM's podcast series, wherein we get to discuss a whole lot of interesting topics with leaders in the field, and a brilliant initiative by ISCCM. For this month's podcast, that is April 2025, we have, I don't know if I would call it an important topic, but at least the, buzzword. Everybody is talking about it. I don't know if we are there yet, but at least it's in vogue. Every conference or CME or whatever discussion, nobody can avoid discussing this. Nothing but precision medicine in critical care medicine or in the ICU. And for this, myself, Dr. Raymond, and my colleague, Dr. Ritesh, are available to moderate. And we have a wonderful guest with us, a very fond teacher and past president of ISCCM, Dr. Ram E. Rajagopalan, who is the head of clinical services at Sri Ramachandra Institute for Higher Education and Research, Chennai. Welcome, sir.
Thank you.
Dr. Ritesh, what do you think?
Yes.
This is a good topic, something interesting, isn't it? We all talk so much about it, but there is still an element of confusion. We don't know if we are actually there. What do you think?
So I think we are moving from, era of we have seen evidence-based medicine to kind of practical-based medicine, or now we are coming to, kind of precision medicine. And believe me, this topic, by and large, what we call in all our lectures, individualized your treatment, individualize your treatment. The same way, we need to be precise. So no doubt this topic is most important in Mindwell. Even if whatever is the topic, we have our guest, Dr. Ram, is going to make it so much, interesting, innovative, as well as informative.
Yes.
So I think it is needed, yes.
So, sir, without wasting any more time, like Ritesh put it, sir, what is this precision medicine? Are we going back in time? Because we used to talk about this art of medicine where every single patient was different. We used to quote on my experience sort of a thing. So are we going back there? Are we trying to individualize treatment and move away from SOPs? What exactly is this thing called precision medicine?
Yeah. Philosophically, I think we are going back there in the sense that we're trying to handle each patient individually. But I think we should understand medicine has always been a science where the individual care of the patient is what matters. Ultimately, you take care of a patient, they need to have a successful result. But what we recognized over several years is the fact that when we are talking about specific diseases, that the pattern of progression and the response to therapy in most patients is quite variable. And we started recognizing this and then said, oh, maybe we shouldn't look at individuals alone. We can look at how the individual will respond by looking at the entire group. So I think we went through this process of aggregating our results. And as you probably know, all our randomized controlled trial and large observational cohorts were created for that purpose. We clearly understand individuals will differ in the way they respond, but on an average, when they're grouped together, they probably will show us an appropriate kind of a way for us to understand the disease and to treat it. Unfortunately, when we did this, yes, our understanding of medicine did grow. We did understand how to treat these patients as big groups, but it was treatments that showed you what the effect was on the population. So you would say that the average individual in a given population was responding to a specific therapy, but it didn't mean a given patient was responding as we expected them to. The whole problem is we started looking at what we call as more population dynamics. And most of what we get from our randomized trials is basically what the entire population does. So we needed to get back to the old idea, knowing that we needed to try to find a way in which we can identify individuals and their responses more specifically. Now, I don't want to consider this as the moving to an older process. Philosophically, it is the same. But I think we need to look at it completely differently because we do have a lot of scientific tools right now that can allow us to identify these patients on their individual characteristics. So what we're talking today about personalized medicine is not the personalized medicine of maybe my grandfather, okay, who probably felt the pulse and then said, "This is what is going to happen." I think on an average, they were able to get away with it primarily because a lot of disease was self-resolving, and whatever you did, you ultimately had an outcome, and you was quite satisfied with that. But ultimately, we have recognized that that is not the way that we can proceed. So that is the difference in the personalization today.
Okay, so in other words, you mean to say we have moved from art to protocolized medicine to something else, which is this
Yeah,
precision medicine, and we arrive at this precision medicine using scientific tools. So we are again not losing out the scientific basis for that. So by practicing this, do you expect that we are going to get better at identifying disorders or better at
yeah.
treating people? Is it really going to matter in that
Sure. I
context?
think we need to look at this in that way. Okay. So when we initially developed these large randomized controlled trials, which showed on an average some patients were responding and some were not, but on an average you had good outcomes. Okay. Under those conditions, what we consistently saw, and we see it again in many randomized controlled trials right now, where you have a good scientific basis for a specific therapy, but the outcome that you see is averaged out. There are some people who respond, some people who don't, and the net effect is an average non-response. So it's not surprising that you see large numbers of RCTs which don't give you any kind of result. So very, very clearly, we needed to be able to subset these patients, the responders versus the non-responders, in an appropriate way. The typical way in which we did this in the past, we always recognized we are dealing with heterogeneous populations and that we can't look at these heterogeneous populations if you want specific answers to therapeutic questions. So, under those conditions, what we did was very typically we would look at varying severity indices. So, if you're older, you're more likely to die. So, or you're more likely to get ventilated. So, we'll keep you in one group. If you're sicker, have a higher temperature, have a higher cytokine level, have a lower blood pressure. So we put all of them together, and we developed these so-called risk identifiers. Okay, and we try to subgroup patients like that. If you really look at it in ARDS, we did that very typically. We saw that only oxygenation was a single parameter that predicted differences in outcome. And so we subdivided patients on the basis of severity into mild, moderate, and severe ARDS. And then we claim that only severe ARDS we have benefits from prone ventilation. We were lucky. But I think that was not the best way in which we can do it. We were not effectively trying to look at homogeneous groups. We were looking at heterogeneous groups that had come to the same endpoint. They had come to a severity, but they were looking very similar, but they are basically very heterogeneous. So, what we need to do at this point in time is to find a way in which we can identify individuals. I can identify you as Raymond, and you can identify me as Ram, and we can look at how Raymonds and Rams will respond to specific disease. And we need to get these identifiers appropriately. This is where it becomes extremely sophisticated. In the sense, the statistical methods that we needed for this, even though it was well developed long time ago, okay, the mathematics was there, but the ability to crunch those numbers required the technology that we have today. The methods that we use are what are called cluster analysis, and cluster analysis requires very high, high computing, and in fact, even artificial intelligence if you really want to make some sense of all these clusters. So, what am I talking about? How do I identify you as Raymond and identify me as Ram? I will basically say Raymond has a specific genetic characteristic that can identify him, and probably all Raymonds, or Raymond's family, who look very similar, can be identified as being very similar to you. In contrast to the Rams, who will have a distinct difference between you and me. There is no question that we can identify this by, genetic parameters, or we can look at, the epigenetic responses. So for a disease, how the genetic parameter interacts with the environment will be quite important. And you look at epigenetic characteristics, and that will give you some kind of an idea. And that is the way in which we are trying to characterize these individuals into subtypes. Okay, and this is definitely a newer methodology. You're not going to be able to pick a given individual and know their response, but certainly we can identify groups of very similar looking individuals by looking at these kinds of parameters. So this is the way it is probably developing. And I can just take one step further and say this has gone to such a level in oncology. Because Raymond, I think you asked me about what about oncology? Okay, where you have the ability to identify by genetic parameters whether a given individual will respond to therapy or not. My personal example, I always like because of a colleague who had a problem with a non-small cell carcinoma of the lung, which was metastatic. And at that point in time, we all thought he's going to die because he's going to get, severe chemotherapy or whatever else is going to do very poorly. But they identified it on the genetic basis as having a specific characteristic that was responsible to a protein kinase inhibitor. He took a pill a day and came back to work without any chemotherapeutic problems and survived it. That was the personalization that they were able to achieve. But that, unfortunately, is not what we are going to be easily able to achieve in critical care. While the genetic parameters may be strong determinants, it is ultimately how it interacts with the environment and how ultimately it presents itself that becomes important. So we don't look at the genotypic characteristics, we look at what are called the phenotypic characteristics, the responses that you have to a specific disease because of your intrinsic structure. And that is what we are looking at. And this idea of phenotyping has been quite prevalent from probably the 2014, the first Calfee paper on ARDS, and subsequently we had a lot of information related to that. So the way in which we are personalizing medicine in critical care is to identify small subgroups of individuals with very identical characteristics intrinsically who will respond to a disease in exactly the same way and thus will be probably amenable to specific aspects of disease manipulation.
So, sir, well said. Yes. Yeah, please, Raymond.
No. As much as I seem to understand that, of course, I was excited listening to you, sir, but so much was above the head, all the epigenetics and genomics. And, well, yes, of course, I think Ritesh has some questions to
ask. But I think I should put that clearly. Okay, it's very clear that a given individual's ability to respond to a disease or to have an outcome is going to be very strongly based on their genetic structure. And that alone is not enough. It is how that genetic structure interacts with the environment. Okay, whether it is disease is a perturbation of the environment. If you look at it, whether it is an infection or whatever else, how it responds to that environment, it expresses itself by that response in very specific ways. So, for instance, when you have an infection or an inflammation, because of your genetic structure, will have a specific pattern of cytokine responses, which will be distinct for you and may not be for me. And my outcome can be clearly influenced by the way these patterns are produced. And this is what we need to identify in individuals before they advance to very late stages of disease. Say, oh, they're going to die, therefore we'll give them on a ventilator. That doesn't make any sense at all.
I think we realized that all the more during the COVID pandemic, isn't it?
Yes.
Yeah.
There was no one size fit all therapy. Ritesh, sorry, you were going to ask something.
Yeah, so the
ahead,
extension of the same, this understanding and concept of identifying subphenotype. Can we put or can we have this kind of precision guided strategies like commonly you say same COVID ARDS you take up, right? We know that many people, many patients have died of ventilator because of VILI. So do we have this kind of medicine strategies to understand, to identify the risk of VILI in patients of ventilator?
Yeah, that in fact has been one of the processes. If you look at what we do in critical care, besides the fact that we can give them treatments, and that has been quite limited because of the ways our approaches have been, we can also identify ways in which we can take care of the patient without creating complications or the problems that you will have when you put somebody on a ventilator, for instance. And this has been quite nicely identified. There have been studies that have identified phenotypes which are based purely on respiratory mechanics. They use up to about close to 50 different parameters to develop models. Again, requires artificial intelligence and big number crunching for you to identify or sub-identify these patients into what they call as recruitable lungs and non-recruitable lungs. Not in the typical terminology, but recruitable phenotypes and non-recruitable phenotypes, which behave completely differently. I have to be very careful. All this has been done on retrospective kind of databases, okay, where people have looked at these parameters, made the differentiation, and then have looked at how these responses have been in those subgroups. Okay, we definitely need to test it in prospective subgroups, but there is some exciting information to suggest that the ways in which we treat patients can also be different, particularly ventilation, particularly fluid therapy. There's a lot of data that says that subphenotyping these individuals can be of some value.
So, coming to the same, sir, like, we struggle with fluids and vasopressures. More fluid, less fluid, more vasopressure, less vasopressure, first fluid, second vasopressure, and so on and so forth. So, can these strategies, precision-based strategies, help in identifying titrating of fluid or fluid identifying fluid responders or vasopressure responders? That will make our life easy, that right just.
It can be done. Okay, if you go back again to the classic studies, there's a study by Seymour, which was in 2019. Derek Angus was part of that group, where they identified 4 different subphenotypes of sepsis. Okay, what they call the alpha, beta, gamma, and delta. Okay, and they showed in a simulation model. Unfortunately, they looked at using a randomized control trial data where they had the same phenotypic information that they had on these patients. We used that simulated data to show that, for instance, response to EGDT, early goal-directed therapy, which is definitely part of fluid and vasopressor therapy, was distinctly different in these subphenotypes. So by knowing the subphenotype, you'd know who would respond to EGDT. The whole idea that EGDT is useless sort of probably will annoy the people who did the initial studies, which showed that it was very successful. Then after that, we have taken very heterogeneous groups and basically said it's useless. But if we can identify these subphenotypes, it can make a big difference. So in that sense, the Seymour study is something that gives us that information about that. Even more interesting is, again, to use an Indian name over there. There's a guy called Sivasubramaniam Bhavani. Okay, I don't know whether Bhavani is probably his hometown. He has done a lot of work. I think he's based out of in Atlanta, I think. He's done a lot of work on what are called these trajectory-based studies of your vital signs. So basically, how your vital signs change over a period of short time. Okay, the direction of your temperature, the direction of your blood pressure, basically using those vital signs. And he developed subphenotypes based on that, and he demonstrated that there is differential response, for instance, to the use of the traditional normal saline, or to the use of these the salt solutions that are currently being pushed very hard. So I think there has been ways in which you can subphenotype individuals and identify which of them will demonstrate a response. So there is a lot of promise in that. Please remember, as much as I say all of this is all derived on retrospective data.
Yes.
And it at best is theoretically possible. And this is something that we need to probably try to evaluate more in prospective studies in the future.
Because we often talk about, we are more interested in ventilatory strategies, hemodynamics, but this is going to be applicable for almost every intervention, every therapeutics that we apply in the ICU, I'm sure, like identifying appropriate renal responders or identifying antibiotic responders, whatever therapeutics, I'm sure. Yeah.
So just to extrapolate a few of these ideas, I've not seen much work on renal phenotypes yet, though there are people working on it. But there has been phenotyping.
AKI phenotypes, yes.
Yeah, I think the people are working on it right now. But more typically, some of them are not really phenotypes. The people use that word phenotype very loosely. I think we need to be very careful about the methodology that we use to identify. It has to be high quality cluster analysis. okay, which is probably the biggest problem that we face with most of them. But there has been a subphenotyping, say, for instance, of cardiogenic shock, okay, which show differential responses to mechanical cardiac support. So, for instance, they have identified 3 different subgroups. One group, just you give them any kind of mechanical cardiac support, they die. The other 2 groups seem to benefit from a process of using the microaxial devices. So it seems like there is a lot of scope for this, and it's growing. It's not just in ventilation and volume support, but also in other therapeutic aspects that are relevant to us in the ICU.
So I'd like to pull you back to one of the discussion that we just had, sir. You already described about the cancer, genomics, and identifying people. How do you see that coming up in critical care? Of course, we already did discuss about the problems of heterogeneity and so many lacunae over there. But I'm so eager to see if pharmacogenomics can really be applied in critical care in our units where we use so much of pharmacotherapy without knowing if somebody is going to respond appropriately or not.
Yeah,
Where do you
no,
see we are for?
absolutely. Pharmacogenomics, the origin definitely, and the advance that we've seen up to this point has been dominantly in oncology. There's no question about it. And as a process that we can immediately apply to critical care, I think it is not possible yet. But there are plenty of ways. We can identify by the genetic characteristics how a given individual would respond to a specific therapy. We know, for instance, we talk about all these patients who have differential responses to succinylcholine, right? The paralysis, some people have a different response. If we can identify the genomic structure of it, we can easily, identify who would be the ones who will get the adverse consequences of using neuromuscular blockade. And this can actually be extrapolated to quite a lot of what we see in intensive care. The adverse effects that we see can be probably identified in advance by knowing the underlying genomic characteristics. As much as I see this in the future, I have not seen much of. There's been a large amount of work in terms of pharmacological responses and genomic subtypes. But whether it has come to the point of anywhere near applicability, I'm not very sure. It'll probably only confuse and increase the cost of care at the present time.
So
But I
it
think
makes
it
it
is
appear
challenging.
more like a
It,
sci-fi.
yeah, it
Yes,
does.
challenging, but I'm sure we're heading there.
Yeah.
And it's quite thrilling to see. I really want to look at those things implemented in our ICU and get to use them before it's
Yeah.
too late. I can't
No,
wait to see
it'll
that
be lovely if
involved.
I can basically, yeah, say you're of this genotype and this is what you need to get in terms of your therapy. It'll be lovely. But I think again it's a little far-fetched because of
But
the
will
heterogeneous
that
response.
take out the intelligence out of us?
No, again, everybody just gets so confused about this. The belief that artificial intelligence is a replacement for human intelligence is about as wrong as things can be got. Remember, intelligence is a whole spectrum of the way in which we handle information and manipulate it. Okay, very, very clearly, we are very good at creative processes. I don't think machines can create in any way. But on the other hand, machines are extremely good at memorizing large volumes of data and manipulating them. If you look at disease basically as our treatment of disease or identification of disease, for that matter, diagnosis, is always based on how many parameters you can remember and how you can put all these parameters together for you to identify a specific disease. But as you recognize, we are limited. We can look at probably 4 or 5 different parameters at a given time and identify a specific issue. Machines can do it at probably many millions of times more higher levels with a greater level of sophistication. Their ability to get these kinds of associations, which are very essential for diagnostic processes, it's just going to be amazing. They are going to be significantly better than us. And in that sense, I love the way, okay, our fear of, artificial intelligence sort of manifests itself. So there was this randomized control trial that was reported in JAMA. I don't remember. I don't know whether you've read that. Okay, where they basically gave clinical case scenarios to three groups. That is clinicians who are allowed to use ChatGPT, and the third was just to the ChatGPT
I've read
simulator itself.
this.
And basically, what they saw was when clinicians were given the ChatGPT, they did not perform any better than clinicians who didn't have the ChatGPT. So you would almost say that artificial intelligence adds nothing to your information in terms of processing. But the ChatGPT itself had better diagnostic ability than either clinician group. The argument that you can say is if physicians are given ChatGPT to use, we interpret the results of the ChatGPT. If it tells you something that you don't believe, we sort of dismiss it. This is what we need to recognize, that sometimes artificial intelligence, in the way it is currently available, has the ability to recognize patterns that we do not recognize. And we need to learn how to adapt to that. And I think that was such a dramatic study. It's not a very large number, 50 patients, 50 people randomized into two groups. It is like absolutely thrilling to see something like that.
No, but the
Artificial
catch
intelligence
there,
is, it's not a threat at all.
it is for our current level of intelligence.
Yeah, that is very true. Okay.
Yes. So having said that, yes, risk, we understood that you made it clear and people started studying it. But what about ethical concerns?
Yeah.
Because it's a big boom. Anything that we do, especially in our, to our sick patients, any new technology, any new approach or whatever said and done. But there are definite ethical concerns. What do you think about this, sir?
I think it's very difficult, basically. I don't agree with, because I think on a consistent basis, these kinds of processes are only improved on by the existence of artificial intelligence. It's not a replacement. It is not like you're asking, oh, AI machine, you do the diagnosis and I'm going to stand by. You're going to use that and interpret it, and it's going to be very essential, because we do recognize that even AI machines as they exist right now have the capacity to hallucinate, to give you false answers, that we definitely need to have some control over the way in which it is presenting or analyzing the information. And I think it is not so much, I don't view it as a major ethical concern, but it's only the big feeling that, oh, you're replacing a physician with a machine, that makes you feel that way. I don't think we are replacing physicians with machines yet. What we are using is we are using their capacity to improve our quality in terms of the diagnosis. And I think that will be completely acceptable. If you really look at it, in an era where we were looking at the pulse and looking at the respiratory rate and making diagnosis, we then moved on to era where we have echocardiograms and electrocardiograms and laboratory tests that will improve our diagnosis. You can't just say those are the outputs of those machines, and therefore, we can't give that any kind of credence. That's not very true at all. I think that is what we are progressing. We are progressing on to methods that will assist and improve the way in which we make our diagnostic decisions. And that is going to be, to me, just is not at all an ethical problem. It is how we, demonstrate or show it to the public that really will matter.
So they it's like complementing each other. That's the way that we have to look it forward. And
I think, yeah,
kind of completely AI in ICU, yeah. AI in ICU.
It is complementary. It's not going to be a replacement. We are not going to see robotic doctors running around in the ICU doing all of that. Please remember, that is again a characteristic that machines don't have. That empathy, the ability to understand an individual and to respond appropriately is something that is such a human characteristic. That is exactly what I said. There is a value to human intelligence in the sense that both the creativity, the empathy, those are the kinds of parameters that artificial intelligence just does not have. And I don't think we need to worry about, that kind of a process yet.
It may not take too long to write a code for sympathy and empathy.
I hope. I don't know, again, how you define it. We'll have to see.
So, as you were talking this, I was just wondering, then what happens to all our existing protocols, all this, let's say, sepsis guidelines and the bundles of care, so many things which are all that typical one-size-fit-all thing.
Yeah, but remember, those were not bad in the correct context. In the context of the way we were looking at medicine, we needed to have those standard operating procedures, as you call them, right? SOPs. Okay,
Yes.
that standardize the way in which we provided care, so that we continue to provide, on an average, good care to guarantee the maximum good outcome under the circumstances that we're working on. But as we get into an issue of personalized medicine, that becomes a little bit more archaic. You're not going to be able to apply a standard general process to the management of everybody. There still may be some which will be very similar, but I still think we need to learn that as we individualize care, we have to move away from these standard guidelines, which are directed at populations, not at individuals.
So probably it would not be more, I mean, kind of awkward to say that we might have SOPs to use precision medicine. Who knows how to utilize it a little
You will
later.
have too many SOPs for so many phenotypes, Ritesh.
Yeah,
Yes.
no, that is the problem. I think we have not come to that point yet. What
Yes.
about the application of all these ideas? It is going to be very problematic. If I say that I can identify a phenotype by looking at 45 different characteristics of a given individual, unless I have a machine that can number crunch for me instantly, I won't be
Yes.
able to identify them. Okay. And interestingly, the ARDS people, I think the CAFE group has actually worked on this. Okay. Where they are trying to look at, uh, I don't remember this group or whether it's the same or group, but they're basically looking at a small number of parameters. Say, let's look at these four. These are the ones which are strongly correlated with the phenotypic subsets. Can we use these four to identify these phenotypes in a good way? I think there is an ongoing trial that is going on, including, I believe there are some people in Calicut who are doing that, part of the
Oh,
same trial. Okay, it is interesting. What they're trying to do is probably identify a what you call a parsimonious model, a model with fewer parameters that can identify subphenotypes and allow you to make these decisions a little bit better. Till that point in time, I think we're going to sit over there and say, "Oh my God, we need an artificial intelligence machine to be the overlord."
right.
And how feasible is it going to be to implement in our Indian setup? Let's say
Yeah.
everything happens, we have them all.
I always like that word Indian, okay? But because India is again heterogeneous, there is no such thing as India in terms of healthcare or in terms of given there is nobody like a typical Indian. So there is a huge variability in Indian healthcare as we see. And particularly if you look at the urban corporate sector, they have gone on very rapidly to digitize their records, to make it all paperless, really have made electronic record keeping their prime aim. And I think once you start with that, subsequently going on to using phenotyping methods and all of that becomes dramatically easy. The challenge is trying to get it applied across the board everywhere. So I think, okay, Raymond, you in your, I'm not allowed to name your institution. Okay, in your advanced institution, probably will have the lead as far as being able to jump onto these kinds of processes. Ultimately, I think once we get good computers that can crunch your data, I think you can easily start applying these kinds of issues, at
More
least in
than
some
jumping,
areas.
I would assume it will be a seamless integration. We will just gradually learn, and the learning curve will just take
Exactly,
us
exactly. It
there
Yes.
won't be someday when,
one
yeah,
fine
you're
day.
saying, oh, of course it is true. It will be very seamless and it will be, again, in pockets. Some institutions will be
Yes.
able to do it and some will not be. It will take a long time for the uniform application. It can be quite expensive to really look at it. There again, these kinds of parsimonious models, models which use fewer parameters to identify subphenotypes, are probably important. And again, I'm not going to be a pessimist over here and say the technology will not catch up. Maybe it'll catch up to the point where you can look at 15 cytochromes on any given patient with a drop of blood sometime soon. Okay. Cytokines, I mean, did I say cytochrome? I'm sorry. So cytokines on, you can look at patterns, you can see the evolving patterns. You can do a lot of things probably with technology rapidly changing. So I'm not going to look at the crystal ball and say, I know how slow it will be. I think it can be faster than I anticipate. Okay. I
You
worked
mentioned it
many
could be
years in
expensive, but
cardiology
I'm
research. Okay. I'll just give you an example. I worked many years in cardiology research. Okay. And the technologies that I was asked to use, which I rejected, okay, have become technologies that are very important. In the 1980s, when the first esophageal
oh,
probes were introduced for transesophageal echo, I was the first one to say it is too fat. You can't put it into anybody's throat. It is such an inconvenient kind of a process. And I went on to looking at it only with transthoracic echoes. I think big mistake. I think we've learned a lot. And there is no way that we can predict technology. Anybody who claims that they understand it and can predict the
Yes.
future is not necessarily saying anything.
So, sir, just after so much of discussion, one concluding question and very, point blank. Are we yet in the era of precision medicine?
I love that because I have a slide at the end of all my talks with basically a kid sitting at the back of the car and asking the famous question. Every time you've taken your child out for a ride anywhere, the first thing that they will ask you is, "Are we there yet?" Okay, and the answer to that will be a irritable, angry, saying, "Shut up, we're not there yet." And the answer to this is also going to be the same. Are we there yet? No
five
way are
minutes.
we there. But I'm bloody optimistic about the whole thing. I think within a year or two, I think there's going to be changes that are going to be dramatic, not just in the technology, but in the acceptance. Okay, we come to a point where any one of us will say, I was actually saying that it's about time that with my fading memory that I should be replaced by GPT-3 or GPT-4 right now. It has a greater ability to remember the facts and to translate that into an effective option. I think we are getting to the point where we accept certain aspects of artificial intelligence. We recognize that it can be a major aid to the way in which we handle all of this. And I think I'm very optimistic. I don't think we need even 5 minutes, Raymond. I think right now we may not be there yet,
No, no,
but
not
we
that five
will
minutes.
get
I
there
said,
soon.
Daddy, how long are we to reach 5 minutes? That 5 minutes is like, something that you never get to define.
Oh,
It's
okay.
also like
Okay.
when
Or
you
just
ask your
about
wife,
to
"Are you
reach.
ready?" 5 minutes.
Yeah. Yes.
No,
Just about to
I
reach.
hope it
Just
is
about to
really,
reach. Yeah.
I hope it is really closer to the 5 minutes than a few years. Okay.
Right. Right. So I think we had a lot of
That was
discussions.
wonderful. That was a wonderful
Yeah.
conversation.
Yes. Yeah. Any concluding remarks, sir? Still, we have thrown a lot of questions, but just in couple of words, sir, if you conclude kind of remarks for this topic, sir.
I am a strong believer that personalization of medicine is necessary in the sense that we at least need to identify small groups of behavior that will guaranteed improve the ways in which we can provide them with treatment. We couldn't have done it by just hoping that Raymond and family will behave the same way as their group alone, and my family will behave differently. We need to have a little better set of tools. What we have right now, whether it is genetic or whether it is basically based on phenotypic kind of mechanisms, have a way of identifying some of these subgroups. We need to identify the problems that we face with the complexity of the analysis, and we need to refine the methodology. But I think ultimately, once we personalize care, it is going to translate into something dramatically different from what we are seeing.
Thanks a lot, sir. Dr. Raymond, anything further to say or ask,
No, that
sir?
was brilliant. That was a very nice chat. I think I just missed some beverage.
Yes, no doubt about it. So thanks a lot, sir, for, as I earlier said, this is kind of innovative topic and you really made it not so simple. We know that we are yet to be there, even in understanding. But yes, it is
5 minutes.
interesting. 5 minutes concept or about to reach concept. So let's hope to reach there soon with kind of thought process that you have. It encourages the young generation to be there sooner than 5 minutes. Let's hope for the best. So I thank on me, myself, Dr. Ritesh Shah and Dr. Raymond. On behalf of ISCSM, I thank you, sir, for spending this much of time, almost we have 40-45 minutes for this interesting topic. I think nobody better than you can take up this topic. That's what Raymond thought initially, and I completely agree with that. So thank you, ISCCM President Dr. Srinivas Samvedam, General Secretary Dr. Sachin Gupta, and this program, that vodcast, we are continuing under leadership of Dr. Ranveer Tyagi, who is President-elect. So once again, I hope our audience had got a lot of good messages, little adrenaline to rush towards this shortening of this 5 minutes. Definitely interesting, innovative topic, and many more to come. So on behalf of ISCSM, I would like to tell each and everyone, please follow ISCSM on our all social media pages for more and more interesting and innovative sessions. Thank you. I think we are concluding this session. Thank you.
Thank you.
Thank you so much.
Thanks.